Hello, I'm so happy to be here today to talk to you about symptom management in oncology and empowering the oncology nurse. My name is Pam Ginex. I'm the Senior Manager of Evidence-Based Practice and Inquiry at the Oncology Nursing Society in the United States. I have a long history. My entire career has been in oncology, and I'm just thrilled to be here today to talk to all of you about something that I find very near and dear to my heart. And I'm sure that all of you do as well, and that's symptom management for our patients. I do want to say, starting off, that I encompass symptom management to include toxicities, side effects, anything that our patients are experiencing as a result of either their disease or their treatment. And I just use symptom management to, kind of encompass all of those different terms. So I wanted to start off with just a quote that I always go to. I find this very inspiring. This is from Dr. Peter Pronovost, who's involved in patient safety and quality improvement at the Johns Hopkins Hospital in Baltimore, Maryland, here in the States. And he said that indeed, nursing should address evidence-based practice to the same degree that they tackle giving compassionate care and holistic care to our patients. Our patients deserve nothing less. And I kind of interpret this as him saying, you've got this. Nurses know what to do to give holistic and compassionate care, and we know what to do for evidence-based practice and symptom management for our patients. So I really look at this as, empowering and sort of a call for him saying, we've got this, we can do this. I don't have any disclosures other than I am an employee of the Oncology Nursing Society, and I will be talking a little bit about some of our guidelines and different products that ONS has, in addition to some from other organizations as well. The objectives of my talk this morning are to discuss the importance of symptom management for patients with cancer, to discuss the role of the nurse in symptom management, and then to also explore the use of guidelines in symptom management, how guidelines and other resources can help us. And then to also highlight best practices for several prevalent cancer symptoms and side effects. So we'll start by just talking broadly. We all know that symptom management is really foundational to cancer care. And we also know that we as nurses are really oftentimes the first point of contact for our patients when they experience a symptom or a side effect of their treatment. There's some research now to back up the importance or the impact that symptom management can have. And I think this is something that we as nurses have known all along, but it's nice to now have data to back this up and to actually enforce what we all have known through our patient care for quite a long time. We now know that good symptom management can extend survival for our patients. This was a study that was completed here in the States by Dr. Ethan Bash, and he had at a hospital, they assessed 12 common cancer symptoms in patients who were undergoing chemotherapy, and they did this proactively. So every week they would ask the patients about these 12 symptoms. Do you have them? Yes or no? Is it, how severe is it, or is it bothering you? And just routinely, proactively ask patients. And that was the experimental group. And then the control group just got standard quality nursing care. If symptoms worsened, if patients reported that their symptoms were worsening, it triggered an alert to the nurse. And over 3/4, 77% of those alerts actually led to a clinical intervention. And what he found was that at the end of the study, patients that were in this symptom management proactive group actually had a longer survival, 5.2-month median survival difference between the two groups. And the 5-year absolute survival benefit was 8% higher in the patients who got this proactive symptom management. So I think it shows us what we've all known, in that we as nurses know that when we do pay attention to our patients' symptoms, we ask them about their symptoms, we follow up with them, it makes a difference for them. And there was a second study that looked at symptom management in palliative care. And this was an intervention that included expert symptom management, coping strategies, understanding of their illness. And this was in a group of patients with lung cancer. And what they found was that the patients that got this sort of enhanced symptom management had better quality of life, better understanding of their prognosis, had less depression and anxiety, and actually also had a survival benefit, 2.7 months longer survival. So I think both of these studies, again, show us what we know as nurses in that when patients' symptoms are well managed, they do better. So there's a lot of roles that nurses play in symptom management, and that goes across the disease trajectory and across the treatment options that patients can undergo. In surgery, nurses coordinate care both before, during, and after surgery. We monitor their status, and we also manage both acute and long-term complications of surgery. For patients getting radiation therapy, we provide supportive care as part of the radiotherapy multidisciplinary team. Patients getting systemic or chemotherapy, systemic therapy or chemotherapy, we educate and communicate with the patients and their families about their treatments and what they should be expecting. We have expert technical skills in administering these agents, and we also monitor for adverse events as a result of these agents. We also improve patient care, are documenting our assessments, applying evidence-based practice to our patients, engaging in research to help develop evidence for our practice. And then we also build oncology expertise and resources. So we are involved in training nurses in safe handling and administration of chemotherapy, evaluating labs and calculating drug dosages, assessing their catheters. And we also participate in supportive care research. And I'll talk a little bit more about how nurses participate in research for symptom management a little bit later on. So what resources can help nurses with symptom management? And I think about this a lot. There are a number of resources that are available, but we can't do this alone. So I think about the proverb that, and I'm going to paraphrase here, but says, if you want to go fast, go alone. If you want to go far, go together. And I think of that often when I'm thinking of symptom management, because in order to go far, we do have to go together. So we do have to work among ourselves as nurses and among our multidisciplinary colleagues, and then also with our patients as well. So one of the first resources that I did want to talk about and spend some time on was guidelines. And not all guidelines are created equal. So I'm going to spend just a little bit of time talking about what they are and what makes a good guideline. But guidelines are really clinical practice statements that include a couple of key points. One is that they have recommendations intended to optimize patient care. So they should be telling us this is what patients we should be doing for patients, or maybe this is what we should not be doing for patients. But they really have specific recommendations included in them. A very key point is that they are informed by a systematic review of the evidence. So we really do a thorough review of all of the evidence that's available and make a recommendation based on that. This isn't based on one study or one person's clinical opinion or their experience. This is really a systematic review of all of the available evidence. And then lastly, they include an assessment of the benefits and harms of alternative care options, because maybe something is beneficial, but it has significant harms. And that's important for us as we're talking with patients and as we're making our clinical decisions. So those are the three key points that are involved with clinical practice guidelines. And why are guidelines so important? When we think about getting to our goal of evidence-based healthcare, there's some steps that we have to go through first to get there. So there's this whole progression, and it starts with generating the evidence. We need the research, we need mentorship, we need funding for that research to build that evidence base. Once we have that evidence base, we need to somehow synthesize it. I doubt that any of us have time to read hundreds of articles a month that are coming out across the world on research for patients with cancer. So we really need a way to synthesize and pull all of that evidence together. And that's through systematic reviews, that's through publications, that's through sharing evidence in professional meetings such as this one. And then once we have that synthesis, then we need to take it to that next step to say, what should we do with this evidence for our patients. And that's through evidence-based practice, that's through guidelines, which are an excellent way to do that, through practice standards. All of these steps lead to evidence-based healthcare, which is when we have evidence, we have our clinical expertise, and we also consider patients' preferences and values. And those three key components come together to really give us the best care for our patients. And this knowledge translation going from research to evidence to guidelines and then to practice is really our goal. And guidelines are a key part of this trajectory. And then just very briefly, I wanted to just highlight what's involved in guideline development. As I mentioned before, not all guidelines are created equally. And you do want to know kind of how the guideline was created and what went into it so that you can feel comfortable using that evidence in your practice. So when you build a guideline, you first form a guideline panel, and this is interprofessional. It's nurses, doctors, dietitians, therapists, whoever has expertise on that topic, as well as patients. The patient voice is very important here. That panel convenes and they develop clinical questions. So they really ask themselves some hard questions, like what do our patients, where is there uncertainty in our care? Where do we not know what to do? What are the questions that our patients are asking? What are the questions that we're asking as professionals that we don't have an answer to? We give those questions then to a separate team who conducts a systematic review to determine the evidence base. Once we have that evidence, we give it back to the guideline panel. They review it and they make recommendations, those recommendation statements that I had mentioned, and that really forms the guideline. So the guideline is really a publication or a document, and then we have to publish it and disseminate it. And that's, each of these steps are important, but the dissemination piece is probably key. A guideline doesn't help anyone if it's sitting in a journal or sitting on a shelf. We need to make sure we get it into the hands of the people that need it, the patients that need it, and also at the point of care. So how can these guidelines help us when we care for our patients for any symptoms, side effects, toxicities that they may be having? As I mentioned, guidelines synthesize the evidence so that we don't have to. There's just too much evidence out there for all of us to be absorbing it all ourselves and making sense of it all. So the guidelines take that heavy lift and do that for us. The expert panels that are involved review that evidence and then make those recommendations. So where as an oncology nurse, I may say, well, I have a lot of experience, but my experience is limited to, where I practice and the patients that I see. Somebody in another, country, in another part of, even within my own country, may have a different experience. A multi-professional colleague may have different experience. So bringing all of that expertise and perspective together is important. Guidelines can help reduce inappropriate variations in practice. We all should be doing what the evidence says we should be doing, but we also should stop doing things that have not proven effective. If we're doing something that isn't helpful, that's preventing us from doing something that potentially is. So guidelines can kind of help us weed through that and help us say, well, this is what we should be doing, and these are things that we can back away from because they really aren't as helpful as we thought they were. And by doing all of this, guidelines can help promote the delivery of high quality, evidence-based healthcare. So I'll talk about a couple of examples of guidelines next to give you an idea of how they can be used in your practice. The Oncologic Nursing Society recently transitioned some of our evidence-based practice resources into clinical practice guidelines, and we chose 5 topics for this first set of topics to transition: lymphedema, constipation, radiodermatitis, skin toxicities, and hot flashes. And more information is available at the website there, and I'll talk more about a few of them in detail, in the next few minutes. But these are, we felt, relevant symptoms and side effects for our patients that weren't covered from other national or international guidelines. We felt that these filled a gap in cancer symptom management. And I'll show you what this actually looks like. So on the left here, you see this was the systematic review for the guideline on hot flashes. So this is the evidence base. that the guideline was based on. And it's important to have this, to have strong rigor and transparency with the guideline. So you want to know, how did we make those decisions, and what was the evidence that those recommendations were based on? And that all goes into the systematic review publication. The main publication is actually the guideline publication, and that's the one in the middle here. And this is the one that includes all of the recommendations. It includes a summary of the evidence that the recommendations were based on, and then it also includes all of those other factors that we considered, such as equity, patient preferences and values, feasibility, implementation. All of that is discussed in this guideline. And then lastly, these first two are pretty hefty publications. And again, we know everyone's busy and may not be able to get into, have time to thoroughly review them. So we also wanted to include a clinical summary of each guideline, which is sort of a high level, what are the key points that I need to know? What are the recommendations? Much shorter publication. So that's this last publication here. And all of these form a bundle of resources for each topic. So each one of our 5 topics has these 3 publications available. They also have a dedicated web page on the ONS webpage for that topic that includes these publications, as well as other resources related to hot flashes or related to lymphedema or constipation. And we thought that having that bundle of resources available would help with implementation and help with dissemination. So that's how ONS has decided to disseminate our guidelines, and we're very, very proud of that. I do want to mention that the guideline publication and the clinical summary publication are open access. So if you go to the ONS website, if you're a member, you log in. If you're not a member, you just have to register, and you can have access to both of these publications without a charge. And that was also important to us, that we make these available as broadly as possible. Here's an example of a guideline from ASCO. ASCO has really excellent resources available for treatment, supportive care, survivorship. They also have resource stratified guidelines, and their website is listed there. This is their palliative care in global settings guideline, and these are all available open access on the ASCO website that I have listed there. MASC is another really excellent organization. It's the international multidisciplinary group focused on supportive care in cancer. And there's a lot of nurses in MASC, physicians, dentists, nutritionists. It's a really nice multidisciplinary group. And they offer a few guidelines on antiemetics, mucositis, and osteonecrosis of the jaw. They also have very good assessment tools for chemotherapy-induced nausea and vomiting, teaching tools for patients who are taking oral therapies for cancer, and on skin toxicities for patients on EGFR inhibitors. And the website for their guidelines are there. Costars is a collaboration out of Canada between the Ottawa Hospital Research Institute and nurses in Canada and the United States. They have 17 symptom practice guides for remote monitoring of patients, and the website where they're freely available is there. But it's a really nice resource for remote monitoring, telephone triage, or telehealth. But it's also a nice collaboration that's available as a resource for you. There's other organizations that have guidelines, and this certainly isn't an exhaustive list. This is always changing, but the UK ONS, NCCN, based here in the States, has a number of resources available, including some resource stratified resources for Africa, and then ESMO, which is the European Medical Oncology Society. So next, I wanted to shift a little bit and talk a bit about guideline use in cancer symptom management and give you some examples for practice. The first one that we'll talk about is chemotherapy-induced nausea and vomiting. As we all know, this is very prevalent in our patients. Up to 80% of patients can experience CINV. But we also know that appropriate prophylaxis can prevent nausea and vomiting in up to 80% of our patients. So this, I think, is a really good example of we know what to do, but yet we don't always do it. So, where is that gap and what can we do to help bridge that gap? One thing is to certainly be aware of the emetic potential of our treatments. Are they highly emetic, moderately, or low? What is the risk that the patient is going to experience? Patients who are younger, female, poor performance status, or low alcohol use may be at higher risk for nausea and vomiting. And we know from guidelines from ASCO and others that there are very, very effective antiemetics. So if somebody's on a highly emetogenic treatment regimen, they should get a 4-drug combination of antiemetics. If they're on a moderately emetogenic regimen, there's a 2 or 3 drug combination. And then if their chance of, or their risk of nausea and vomiting is low because they're getting a low emetogenic potential agent, there's a single drug that patients should take. So we have sort of the antiemetic or the pharmacologic side of this really well covered. However, there's insufficient evidence to recommend complementary or alternative therapies for our patients. And I think this is really a gap in practice. So, what are those other options that outside of pharmacologics that may be helpful for our patients? I think there's a need for more research here. And we also have to make sure that we incorporate these recommendations into practice, that patients are getting the antiemetics that they should. And I have a nice example of a project to look into just that. So this is just an exemplar of using guidelines in practice. And this was from a nurse who completed this quality improvement project as part of her DNP education. And she was interested in antiemetic guideline concordance. So are we doing what the guidelines say we should be doing? And she wanted to use education to improve adherence to the guidelines and also reduce incidence of chemotherapy-induced nausea and vomiting. As I mentioned, it was a QI project. Her intervention was very, very straightforward. She did a chart analysis to determine how many of her patients had CINV. We always have to know where we are in order to know what we need to fix or improve. And then she conducted in-person staff education on the new guidelines to make sure that staff were aware of what any changes were in the guidelines, what was recommended for patients based on different treatment regimens. So before her educational intervention, she found out that about half of her patients were experiencing CINV, and only 7% of the patients were getting guideline concordant care or practicing to, the clinicians were practicing to the guideline recommendations. After her educational intervention, the rate of CINV dropped, went from 49% to 37%. And also the adherence to guidelines increased threefold, so from 7% to 22%. Now, this still isn't as high as we would want it to be, but she saw a significant improvement just from her education. And she also did surveys that showed an increase in knowledge of chemotherapy-induced nausea and vomiting among her nurses. So what did she learn from this, or what did her team learn from this? They learned that education is effective to update staff on guideline changes, and that's very important. Guidelines change, evidence changes. We have to update guidelines, and we need to then continually to update staff about those changes. Importantly, she noted that clinical practice should be evaluated to assess rates of nausea and vomiting and guideline adherence. And I think this is really important. We have to know where we are in order to know what needs to be changed. If she didn't do this, maybe all of her patients were doing okay with nausea and vomiting, and she could focus on another gap in practice. But until we, kind of have that documentation of where we are, we don't know where those gaps are that we need to improve. she noticed education works. When we educate staff about the guidelines, they improved their practice to the guidelines. However, education alone may not be enough. Where she saw an increase, there was still room for improvement. So having something like a standardized order set can help improve adherence. But again, then they need to be kept up to date. So if the guidelines change, you need to educate on the guidelines, but if you do have standard order sets, those also need to be changed. So you can see how this is not a simple fix. There's a lot involved, as we all know. So having education in addition to standard order sets could possibly help. And also prompt and accurate patient assessment prior to and during treatment can help ensure prevention and management of CINV. So really proactively, asking patients how they're doing and intervening as early as possible are important. And one other key point that I wanted to note here, that she also educated staff about how their individual patients, or maybe not individual patients, but how their practice was doing with CINV. Many of the staff weren't aware that half of their patients were experiencing CINV. And that feedback about their particular set, their practice and how their patients were doing was very important for the staff. The next symptom I wanted to talk about, or side effect, is lymphedema. And as we all know, lymphedema is a chronic disease that can significantly affect quality of life and functional capacity. And here our goal is really early diagnosis and treatment. If we can catch this early, if we can intervene early, we can either minimize or even halt progression to more severe cases of lymphedema. And patients are at lifelong risk after surgery or radiation therapy. So anytime the lymphatic system is damaged or altered, patients are at lifelong risk for lymphedema. We do need to standardize how we measure for lymphedema and improve reporting so that we know exactly where and when and who this is, who is at most at risk for lymphedema. So that's an area that we can definitely make some improvements. And ONS recently published a guideline on lymphedema in patients with cancer, and the interventions that we recommended or didn't recommend were grouped into three main categories. So prospective surveillance, risk reduction, and then actually treatment for lymphedema. So we did recommend that patients who are at risk for lymphedema have prospective surveillance. So pre and post-operative surveillance that includes education about lymphedema and the possible signs and symptoms of lymphedema, limb volume measurements, as well as symptom assessment. We do need to learn more about, the key components of a prospective surveillance system and sort of what are the timeframes for follow-up after surgery or after radiation. So we still have a lot of work to do for prospective surveillance, but we do know that including prospective surveillance in your treatment and in your clinical workflow does help patients. For risk reduction, we did say that we recommend starting 7 days after surgery, so after they have a little bit of time to heal, starting some exercise such as resistance exercise or strengthening exercise is helpful. We had recommendations for compression garments for patients with who are at risk for lower extremity edema. And this again is for risk reduction. So this is not for patients who have lymphedema yet, but for risk reduction, we did say the compression garments may delay or minimize risk for patients with lower extremity edema. However, for patients who are at risk for upper extremity edema, we recommended compression garments only in the context of a clinical trial. And this was one area of debate because the evidence, can be not as clear as we would like it to be, but compression garments do have some side effects from them. And the guideline panel felt that for lower extremity lymphedema, the risk was there. The risk was worth it to recommend compression garments to delay or minimize risk, but not for upper extremity lymphedema. And patients who are at risk for upper extremity lymphedema may benefit from massage of post-surgical scar tissue. And then when we move on to patients that are diagnosed with lymphedema, treatment, the panel recommended complete decongestive therapy as standard of care. And complete decongestive therapy includes compression garments, manual lymphatic drainage, exercise, skin and nail care, and it involves two phases. So the first phase is a more intense phase with a lymphedema therapist to work on all of these components. And then the second phase is more of a self-management phase for the patient. And so we consider that standard of care. And then we also recommended adding an active treatment intervention, such as resistance exercise, a water-based exercise, or yoga, in addition to the self-management phase of the phase 2 component of CBT. The next symptom we'll talk about our side effect is fatigue, and this is probably the most common symptom that our patients experience across all diseases and all treatment types. We should be screening for fatigue, and we should look for risk throughout their treatment and survivorship. We should document the onset or duration of fatigue, any alleviating or worsening elements, and how it interferes with their day-to-day activities. I think fatigue is so prevalent in our patients that we could do improve our assessment and screening for all patients. And these are some interventions that are recommended by a guideline from ESMO. They recommend that patient and family education. It can be very important. Physical activity is probably the key intervention for patients with cancer-related fatigue. And while we don't have an exact exercise prescription, we do encourage patients to have about 150 minutes per week of aerobic exercises, and to include 2 days a week of either strength training or flexibility or both. So really walking, any mild exercise, it doesn't have to be, anything extreme, but any exercise, 150 minutes per week, including some strength training or flexibility, is important. They also recommend some psychosocial interventions, such as information and counseling, cognitive behavioral therapy, and yoga. There have been a number of pharmacologic agents that have been studied for fatigue, and really none have shown strong enough evidence to make a recommendation, other than just very short-term corticosteroids for patients with metastatic cancer. So for fatigue, it's really exercise, and that's something that we should be talking to all of our patients about, encouraging them to exercise. And again, just walking, any type of daily exercise like that can be very beneficial for our patients. And other organizations have recommended exercise for cancer-related fatigue as well. The next side effect I'll talk about is radiodermatitis, and this is one that ONS had looked at. Really, all patients who are receiving external beam radiation are at risk to develop some degree of skin reaction. It could be anything from just mild redness to more severe skin reactions. And the most common assessment tool is the RTOG scale, which rates the changes seen on the skin from 0 to 4, from just faint erythema all the way up to ulceration and skin breakdown. And what the ONS guideline panel recommended was, first off, they answered the question, is it okay to wear deodorant or antiperspirant? That's one question that patients were asking, that clinicians sometimes weren't sure what the answer was. And based on the evidence that we had, it's really a patient choice. There's no reason to not wear it, but if patients don't want to, that's fine as well. That's really based on the patient's preferences. Our good practice statement for radiodermatitis was that good general skincare during radiation therapy is washing with mild soap and water and using just a standard emollient cream. It doesn't have to be anything fancy, just your standard cream. The skincare therapies that we did either suggest or recommend were semi-permeable dressings and topical steroids, particularly for the steroids for any symptoms such as like the itching or things like that related to the skin changes. Aloe vera is often recommended for radiodermatitis, but when our guideline panel looked at the evidence, they really said that we need more research on aloe vera. There are just so many different formulations. There's, pure aloe vera all the way to aloe vera mixed with a number of different other things. And we really just didn't know enough to recommend that as a guideline panel, as well as oral curcumin, which is an oral supplement that we sometimes heard patients asking about. We don't have enough information to recommend either of those. The guideline panel did feel that we could not recommend two other topical agents that we sometimes see in radiation therapy, and that's emu oil and calendula. There just wasn't enough research out there to say that we would recommend them, and actually there were some harms, so the guideline panel did issue a statement that they would not recommend either of those. And again, radiodermatitis is just one of those areas where the evidence is all over the place. There are just so many different agents being used, and we really do need more strong research studies in radiodermatitis. This is a significant problem for our patients, and this is really an area where nurses could step forward, and nurses have stepped forward. A lot of the research on radiodermatitis is led by nurses, which is really exciting to see. And I hope that we see more of that in the future, because there's still a lot of room for improvement here. Peripheral neuropathy is very common in our patients. 30 to 40% can experience this. It can be really impactful in their day-to-day life. The incidence does vary by their treatment regimen and their baseline assessment. Patients who are older, have pre-existing neuropathy, obviously are at increased risk. And ASCO has a guideline on peripheral neuropathy, and there are no interventions that are recommended for prevention of peripheral neuropathy. However, for treatment, duloxetine is a medication for pain that is recommended. It relieved pain in 60% of patients in one study that was published. And I do want to highlight here that this was nursing-led research that found that duloxetine is helpful for peripheral neuropathy. So you'll see nurses are doing a lot of really great research in symptom management. We also, our ASCO also recommended assessing the appropriateness of delaying some doses, reducing doses, substituting other agents that may be less risk for the patient, or even stopping chemotherapy if the neuropathy warrants that. And additional research is needed on interventions such as acupuncture, cryotherapy, exercise, or compression therapy. So I think this is another area where nurses can really stand up and conduct some of this research to see what might be helpful for our patients to help reduce the incidence of peripheral neuropathy. And there are a lot of other resources available to help nurses with symptom management outside of guidelines. Aortic has special interest groups, research and training for nurses that can help build your knowledge base in research and symptom management. The African Cancer Coalition has a pain management program and also participates with NCCN to harmonize guidelines, so nurses could be a part of the panels and the teams that are doing that. There's also Choosing Wisely Africa. And the aim of Choosing Wisely is to identify low value, unnecessary, or harmful practices. And as I mentioned before, if we're doing something that's not helpful, it's preventing us from doing something that is. We have a limited amount of time and resources, so we really do need to focus on those that we know or we think are most effective. Of the 10 practices that are included within Choosing Wisely Africa, 8 are related to treatment, 1 to cancer surveillance, and 1 to palliative care. So I think there's more work that can be done here too, as to what are those practices that we're doing that may not be as beneficial as our as we would like them to be, and what should we be doing instead. So where do we go from here? Collaboration is key. As I said before, we want to go far and we need to do this together in order to get there. So we have to work together among nurses from different areas and different practices, and also with our multidisciplinary colleagues. We want to empower our nurses to deliver high quality evidence-based care. Nurses, we can do this. We've got this. We know how to do this. We, need to support each other and use resources that are available and develop resources that aren't available yet. Thinking of guidelines, we really need to work to develop guidelines that are relevant to oncology symptom and side effect management. And that doesn't mean we have to wait until we have the perfect evidence. I don't know that we will ever have perfect evidence in symptom management or side effect management. And even if we don't have that evidence, there's still a lot of benefits to guidelines. Just synthesizing that evidence and showing us where the gaps are is really important. And we also know our patients don't come to us with one symptom or one side effect. They come to us with a whole array of symptoms. And how do these all interact? There was a really nice study that was just done recently here in the US that looked at interventions that help multiple symptoms. So just as an example, yoga. If yoga helps fatigue, does it also help nausea and vomiting, or does it also help other symptoms that our patients may have? So what are those interventions where we may get the best bang for our buck if we recommend them to patients? It may help them across multiple symptoms. So I think that's a really interesting way to start thinking about symptom management in an area, again, where nurses can excel. But all of this has to move into the point of care. So we may have all of these guidelines, we may have all of this research, but if we don't get it into the hands of clinicians that need it and the patients that need it, we're not doing what we need to be doing. So this is really the key point. We have to move all of these recommendations into the point of care and make it easy for patients and professionals to have that information and to act on that information. So I just wanted to thank you for the opportunity to present today. I'm very happy to be here. I wish I was there in person. I hope that at some point we would be able to meet in person and collaborate together. I hope that you are all staying safe, that all of your families and colleagues are staying safe as well in this very challenging time. And I hope that when we're on the other side of this, we can all meet and work together in person and collaborate. I really have a passion and an expertise in symptom management and evidence-based practice, and I would love to talk more about that. If you would like, my email address is there, and that's a picture of the ONS guidelines webpage that I hope that you check out as well. We're just venturing into this, and I think we're so proud of the work that we've done, but we have a lot of more work to do, and we again can only do that together. So thank you so much again. I hope that you have a great rest of the conference and take care. Thank you.